If we look at our system, is it really designed for people to be well? Or is it designed for a revolving door of patients coming in and out every month or every 3 months? What are we doing to equip people with the skills and the tools to be able to navigate life without having to rely on medications if they don't have to? What we have to do as clinicians is really teach our clients to tune into their bodies. And we don't learn how to listen to our bodies. Pain is an alert signal for us. Now, when we talk about being proactive, we're talking about teaching parents how to have conversations about mental health as soon as their kids can talk. Untreated chest pain and untreated depression have the same outcome of death. We don't know exactly how to fix depression. We know about how to, but there's 100 ways to skin this cat. It's just as much of an art as it is a science.
Procrastination is a trauma response. Have you heard that? So it looks like you're coming up on a decade of experience in this space, from the mental health space and running a clinic. There's a lot we could talk on there. Could you share with us a little bit about how you got into the area you're working in and what you're doing now?
Yeah, so when I started my bachelor's degree and really all throughout working on that, I was going to do physical therapy. How the human body heals itself really fascinates me. I woke up one day and thought to myself, I don't know that this is really what I want to do. I had some struggles with a family member and had some conflict there, and saw the on-campus counselors. Generally every university, or almost every university, you can get like 8, 10, 12 free counseling sessions. I utilized those, and it was in those 8 sessions that I realized this is not what I want to do. And I felt like being a therapist was a better fit. So I applied to the University of North Texas with a day left on the application, got into UNT, and everything's kind of been history from there. I've worked in a couple of different inpatient settings. Before that, I worked at a different hospital in the intake department. I learned so much in the inpatient setting. And that was the first time that my idealistic professional self as a therapist really clashed with the business of healthcare. After that, I helped start an outpatient organization. Was with them for about 5 years, really was kind of helping oversee the strategic growth from one clinic to, I think we ended with 12 when I left, and then came here. Our mission is the same in that we want to reach as many people as possible. The need is so underserved for mental health struggles. But we want to do it a different way. If we look at our system, is it really designed for people to be well? Or is it designed for a revolving door of patients coming in and out every month or every 3 months? What are we doing to equip people with the skills and the tools to be able to navigate life without having to rely on medications if they don't have to? Some people may have to take medications the rest of their lives, but if it's an option to not take that medication, we would like to provide you that option.
With a good business model, you would like good long time, lifetime value, recurring revenue. So, in a kind of pessimistic view, perhaps there's a good business case for having that revolving door, as you said. I'm not saying that necessarily is by design. Maybe it's an unintentional outcome. But let's play that out. Worst case scenario, you put yourself out of business because you've healed everyone in the world. Is that a problem? Does that allow you to do other things?
So I think of course we say we want to work ourselves out of a job, but with 7 billion people coming up on 8 billion shortly, we're not going to do that in any near lifetime, right? But if we were able to, I think that would lend itself to working in other fields. If we made it so that therapists were no longer needed, psychiatrists were no longer needed, I think we would still need to be around to do the prep work, because if we're able to help you solve all of your struggles and be able to utilize coping skills instead of maladaptive tools, then you still had to learn those adaptive and protective tools from somewhere. Somebody still had to teach you those. So I think our profession would always exist. It would just be from a more preventative care model instead of a reactive, oh no, we're worried that you might hurt yourself or you might hurt someone else. Now we have to create a place for you that really doesn't treat the problem. It creates a safe environment, but we're not really getting a whole lot of long-term benefit. Does that make sense?
It does, and it's with mixed feelings that I say I believe you have job security. So, um,
Unfortunately.
an interesting thing going from the physical therapy side to more the mental health side. With physical therapy, usually it's pretty like obvious. It's like in your face. Here's a broken bone. Here's a torn ligament. Here's a laceration or whatever. With
Mhm.
the mental health component, as I understand it, a lot of collaboration is required. Yeah, it requires perhaps a certain amount of A/B testing. I know that there's some kind of forms and perhaps exercises you can do that increase the probability that you can kind of identify accurately what someone might be struggling with, even if they don't realize. That's another thing too. It's almost like hypoxia, where the very instrument that you're diagnosing is the instrument you're using to diagnose.
Right.
So it just seems a little bit more challenging in some respects because there's this black box. How do you, coming from the physical side to the mental side, how do you see that transition? Is it fairly addressable, or are there still some challenges with accurately diagnosing, or if that's not the right word, addressing
Mhm.
some of these challenges?
Mhm. So, as a clinician, when I work with a client, I really try to get them to understand the world that they're in, meaning a lot of times we experience symptoms in our body, psychosomatically. So, anxiety and depression can be felt physically. Anxiety, constant butterflies or panic attacks, racing heart, shortness of breath. Depression can lead to feelings of exhaustion or not being hungry or being hungry all the time. So I really like to have my clients tune in to their bodies and listen to what their body is telling them. And then we go through those symptoms and say, okay, well, it could be this. Are you also experiencing your mind running 100 miles an hour? So when what we have to do as clinicians is really teach our clients to tune into their bodies. Your body is telling you that something isn't firing correctly, and we have to listen to it. In this world of, information is at our fingertips and go go go, a lot of times we don't pay attention to and we don't learn how to listen to our bodies. Pain is an alert signal for us, and so we have to listen to our bodies. So for me, the transition wasn't too crazy of one, listening to your body, learning about the body. Um, it wasn't too much of a transition, but I think a lot of clinicians really teach their clients how to listen to their bodies and what it's telling them.
I fully agree. Our bodies are like supercomputers that are picking up all this stimuli from the environment. And then, for whatever reason, we might be disconnected from distraction or maladaptive coping mechanisms, maybe dissociation, or just shutting that off because maybe something painful happened. It was just an easier survival mechanism. One thing that surprised me is how, I guess, well, we compartmentalize as human beings, and just carry on. It's almost like a tourniquet for a certain experience. And it's like, oh, wow, that's been hanging around for a couple decades. And I just never really realized it. Um, I read an article a while ago. So unfortunately, I can't cite it for you right now. But I'm curious. I believe it was the title of it was Procrastination is a Trauma Response. Have you heard that?
Oh yeah. um, so I mean, I think so many things that are kind of in our world can be, but yes, absolutely, procrastination can be a trauma response, because the way that I've seen it play out for folks is that um, anytime they tried to accomplish something, it wasn't done quite right. It wasn't done up to the standards of maybe a narcissistic caregiver. And so rather than accomplishing that task and then waiting for the barrage of you didn't do this right, this wasn't right, man, you're so stupid, man, you're an idiot, which the person may not have said those things, but when you hear over and over and over that you didn't do something right, your internal monologue becomes something much, much worse. So rather than complete that task and get that negative feedback, maybe we just don't do it. Maybe we just wait until the last minute and you cram and cram and cram, and then what you have is what you have. And then there's not a ton to be disappointed about if you spent 6 weeks working on a project and somebody tore it apart rather than 6 hours.
Because even if you criticize me, you're not criticizing me at my best. So my ego is still intact. It's almost like compound interest too, like credit card debt. So if certain needs aren't met from a social perspective, us being social creatures, you can over-index words. So praise or critique, both have an outsized impact, which is unfortunate because you keep trying. It's almost like playing, I guess, the lottery, where you're trying to win big in order to, like, if I can unlock Sydney's praise, that'll make up for my deficit of ego or self-esteem, rather. But then if you critique me, it's too devastating because I'm already in deficit. So then you wind up creating, ironically, perhaps, or maybe understandably in your case, from your expertise, some like safeguards. So you're almost living this like parallel reality, or maybe a 2 steps removed from reality. So it can be challenging to live in the moment, to kind of understand, process, move on. You mentioned one of your desires is to change the way that mental health is treated. It sounds kind of like teach people to fish rather than give them a fish, or have that revolving door. Could you maybe help us understand, in your experience, how has mental health been treated so far that you think is like wrong? And then how are you seeing kind of some steps to address that?
Right. So from just a systemic standpoint, right, there aren't organizations that have everything you need under one roof. Um, there's not one place, a singular place, or if there are, they're few and far in between. There's not a singular place where you can see a psychologist and a psychiatrist or nurse practitioner for med management and a therapist and maybe a dietitian, because we know that diet affects mental health, and maybe an endocrinologist, because we also know that hormones affect mental health, and a gastroenterologist. Oh, right, you see where I'm getting at? It's all so separated, um, that access to healthcare is difficult, and trying to get all of those healthcare practitioners to talk to each other on a regular basis is damn near impossible. So, a perfect system for treating a patient would include everything. Now, when we talk about being proactive, we're talking about teaching parents how to have conversations about mental health as soon as their kids can talk. So, I had someone ask me recently, "Hey, I've got a 8-year-old granddaughter. How early should we start talking to her about anxiety and depression and reaching out to us?" And I said, as soon as she can talk, even if it's just, "Hey, do you ever experience these things, or it seems like you're really struggling with something? If you don't want to talk to me, I can definitely find you somebody to talk to. Is that something that you would like?" Not forcing it on them, but always leaving it out there as an option.
What do you think are the main hurdles from the, I guess you would say, client side or patient side, in terms of uh, seeking mental health? Like I don't know. It seems this is changing, but I do recall there being a bit of a stigma, um, up until recently. You just don't talk about this sort of stuff. Me breaking a leg and going to a doctor is almost like a badge of honor. Like, look how badass I am. But me surviving a traumatic event and then seeking professional help for that has almost seemed like I've offended the gods somehow. So could you maybe unpack what that relationship is like these days?
Absolutely. I think it's twofold. One, affordability, and the ability of clients, of patients, to be able to know exactly what something is going to cost is so difficult. We have at MBO, we have, let me think, one, two, three, four systems to check on verification of benefits. And sometimes all four of them say different things. So we have to provide the service and then wait for insurance companies to tell us what they're going to pay before we can tell the patients for sure what they're going to pay. We try and give them the best guess, but it's just that a guess. So affordability and knowing how much you're going to have to pay for the service. I know that if I break a leg and I go into the ER, somebody's going to come talk to me from the billing department, and I know exactly what I'm going to owe when I leave that session or when I leave the ER. That's not the case for mental health.
That helps. Thank you for that. Also, just kind of the changing mindset in how do you seek, for example, I don't know if every mental health therapist is created equal. Maybe there's a personal bias. Maybe I get along with someone from Texas, or maybe I get along with talking to a man or a woman or whatever, you know. Um, and and also that kind of unconscious, like I barely know myself, if at all. So certain things could be like, there could be like defense mechanisms, blocks, triggers, stuff like that, that would then get kind of projected out. And so it could be, whereas the doctor, I don't know if WebMD kind of changed this. I heard that sometimes doctors are getting kind of fed up with people coming in and being like, oh, I've got these symptoms. Like, no, you don't, or whatever. And sometimes it does work. I don't mean to say it's all bad, but I'm just kind of curious from your perspective, what the changing culture, maybe that's a better word, the changing culture in mental health for clients like trying to seek help. You mentioned the
Yeah.
cost, which is a very good point,
Right.
especially when it's a revolving door model. But
Mm-hmm.
like, how are you seeing a change in kind of how people can kind of assess if someone is a good therapist for them?
Yeah.
And yeah, could you talk about that?
Mm-hmm. So I think the culture and the stigma has definitely shifted from COVID or even after COVID. You know, we had athletes, professionals, celebrities talking about their own mental health, so that made it more accessible and less of a stigma. But there are still some cultural things. There, in Texas, we have the saying, "Pick yourself up by your bootstraps," or "It's all in your head." Well, yes, that's kind of the struggle. If I talk about a broken leg or chest pain, if I go into an ER with chest pain, I'm treated very differently than someone who goes in with suicidal ideation. With If I say I'm having chest pain, they tell me, forget the paperwork. We're going to get you back here. We're going to get an EKG and we're going to get you to the cath lab. For suicidal ideation, it's, well, fill out this paperwork. We'll come get you in a few hours. Then after a few hours, the intervention is, do you still want to kill yourself? It's not really looking at what's happening. It's not really safety planning. Our emergent healthcare system, or that segment of the healthcare system, is not equipped to manage the severity of suicidal ideation. But untreated chest pain and untreated depression have the same outcome of death. And so it's we've got to take steps to be better clinicians, to be looking for better options, to be willing to have those conversations with our client, because I can tell if somebody's not vibing with me. So I'm doing them a disservice if I continue to see them and it's just not clicking. We need to have that conversation, and we need to equip our clients and patients with the ability to ask that question from the get-go. That is something that we should set up in our first session, if not in that first phone call to schedule an appointment. The conversation of, this just doesn't feel right, is a must have, because it's life or death here. Like, we have to be serious about what the outcome is of untreated mental health disorders. And we can't be afraid to have those conversations as clinicians or as clients.
Yeah, like you said, I don't know if training is the right word, but helping like children as soon as they're able to talk understand that this is part of what it is to be human. You've got a brain. It's holding on to information. That information is affecting future information. So it's good to kind of understand that and understand that none of us are alone. We're in this together for better or worse. And yeah, they just understand more of the options. It's almost like driving a car and just discovering that you had all these extra gears that you weren't even using. So it's like, win. Also, just talking about how it kind of comes full circle and the mental becomes the physical. I mean, I would argue they are both at the same time, but cancer, for example, um, some illnesses, and I mean, I'm kind of saying this, setting you up, can manifest themselves in physical ailments. Is that correct? Is that fair to say?
Oh, absolutely. We know that things like IBS and Crohn's disease can be very much so linked to chronic anxiety, um, chronic PTSD, where there's that hypervigilance and always being on edge, not necessarily the type of PTSD where there's like reliving things, but that hypervigilance, always being on the lookout for something bad going to happen. So, I mean, absolutely, we know that there are diseases that are, if not caused by, absolutely exacerbated by the presence of mental health disorders.
One thing that I'd be curious to get your input in is the difference between, you mentioned picking yourself up by your bootstraps, not necessarily solo, but kind of processing, doing like the work without medication versus chemical intervention. And I imagine there's different variables where there's chemical assisted therapy. There's maybe perhaps some extreme cases that you need the chemical intervention for to sustain somewhat of a normal life or whatever. And then there might be some cases where perhaps you don't need chemical intervention and you can do a lot, um, without medication. Could you unpack that a little bit for us?
Yeah, I think it depends on the severity of your symptoms. So, just like every coping skill is a tool in the tool belt, we believe that medication is a tool in our tool belt. If you are in crisis, if you're experiencing life here, medication can bring you down a little bit closer so that we can get some of those adaptive coping skills in place and really installed in your system so that you can use them later. If you're experiencing the world in crisis all the time, you'll never learn an effective coping skill that works time and time again. So we use medications as that tool. I mentioned there are some diagnoses that might require lifelong medication, but therapy is always recommended alongside that. There are lots of studies being done right now about the use of psilocybin with therapy and things like that. I think that can be a really exciting new area. Um, I have There is so much research out there about that I don't feel like I am an expert to be able to talk about it or anything like that. But I think it could be the next EMDR. You know, EMDR, eye movement desensitization and reprocessing, came out as the fix for PTSD, and it's a much more abbreviated treatment modality. I think psilocybin with therapy could be that in our world. Now, will we be able to get over the stigma of treating mental health, something that's already stigmatized, with mushrooms? Is it going to become monetized to the extent that patients can't afford that effective treatment? We don't know. We're just in the early stages. And so I think that's a really exciting frontier for us. But I think, back to your question, it just depends where you are in your journey. If you're struggling to manage day to day, medication is going to help you much more than just trying to do therapy, because you'll be white knuckling it through therapy without any kind of relief. Um, so I think we have to use it as a tool in the tool belt, but it should not be the only thing that we're doing.
Makes sense. And to the point of psychotropics, many like shamans or tribes the world over have used different hallucinogenics with, responsibly, with the help of a guide or guru to help you on that journey. But also, I guess this would have been a couple of years back now. I saw this shift, maybe more than that. I saw this shift with ketamine, where they were seeing better results from ketamine than previously prescribed medication for things like addiction, things like depression. What are you familiar at all with using ketamine?
A little bit. So some of the popular medications right now are Spravato. It's an S-ketamine, so it's like a derivative of the ketamine, capital K. Um, and so it's a nasal spray, and it is also kind of a shortcut to altering how your receptors receive and express all of those neurotransmitters in your brain. There are a lot of really effective treatments in Spravato or ketamine, S-ketamine, whatever you want to call it, is one of those things. But again, it's important to pair it with therapy. We can treat the depression or the anxiety or the psychosis, but to prevent, a situational version of that coming back or to sustain long-term healing, we've got to learn those adaptive coping skills too.
Yeah, I think part of the challenge with your field is it's almost like trying to help someone not speak English.
Right.
It's like that's what they learned in their environment. So that's what everything gets filtered through. It's like, how do I say this in English? How do I say this with what I know? And it's like, no, what you know is wrong. Or what you knew is not right now. It's like it
Right.
was right at the time. I mean, it made sense at the time, but
Mm-hmm.
yeah, it's wild. And I think it helps to kind of pop out and look at it from a new perspective, which, like you mentioned, maybe a shortcut to that is introducing different chemicals. Um,
Mm-hmm.
and also what surprised me, and maybe you know about this as well, is just our mind seems kind of like a chemical factory. Like it's already got a lot of these chemicals in it already, and like receptors for them. And could you talk a little bit about the chemicals of the mind?
Yeah, so we have epinephrine, norepinephrine, dopamine. So epinephrine and norepinephrine, that can be like your adrenaline. Dopamine is that good feeling that happens after you use a substance or after you complete a satisfying task. Um, you do something, you feel good about yourself. That's a release of dopamine. There's also cortisol, that is a hormone that goes through your body. Cortisol is a stress hormone that can affect things like your liver, your kidneys, your blood vessels, and can cause constriction there. So that one can really get you. Um, Bathing in cortisol can lead to brain deformities for infants, for babies. So there's our brain is a chemical factory. Um, Sometimes our brain is creating enough of those. Sometimes it's not creating enough. Sometimes it's creating enough dopamine and um, nor norepinephrine, but we don't have enough receptors. So that's why there are different kinds of medications. You have SSRIs, you have antipsychotics, you have, because it's targeting a different aspect of your brain. Um, so yeah, and we know a lot about the brain, but we also, comparatively to what we think it can do, know very little. And that's why there are so many patients that, if you start a medication regimen or you start seeing a medication management provider for psychiatric medications, it can take 10 years to get on the right cocktail of medications for you if your diagnosis is one that requires kind of that lifelong medication treatment. On average, it takes about 4 years. And that's because we don't know exactly how the brain works. We're just now, within the last 5 years, getting into things like gene site testing, and a lot of parents in particular, but a lot of folks think that when we do gene site testing, we're going to learn what medication works best. No, we're learning how your body processes different medications. So that might give us an idea of where to start with medication trials. And so That's the challenging part about this industry, this segment of healthcare as well, is that, if you have a torn ACL, we know exactly how to fix it. We don't know exactly how to fix depression. We know about how to, but there's 100 ways to skin this cat. And so it's just a challenge. It's just as much an art as it is a science.
It seems like it. Yeah, like you and I, if I understood you correctly, you and I could be like twins, go through the exact same environment and respond completely different to intervention. And so when you're looking at it, going back to like the business model, people don't usually like to see the bottom line say it depends. My conclusion is that it varies, or there's a probability distribution here. And so we're going to lose some people, but the majority should get better over time. It's like, great, sign me up. Here's a blank check. But I guess as we get more data and the probability kind of increases, and then it's also what's nice too is as you help people like maybe not need as much intervention, you're kind of unlocking um, the full abilities of our group organism. So you should have a return on your investment there from like to use business vernacular, not to think of people as dollars and cents, but maybe that's a good kind of segue into the hard kind of transition from ideally wanting to help people live in peace and harmony and the fact that it takes money to do just about anything. What have been kind of what's been your journey kind of navigating both worlds of business and healthcare?
While I was working on my master's, I worked at a local grocery store. I was a receiver and had a boss that was not great with computers, and so I did the books as far as our P&L and L and our general ledger and all of those things. So I learned how to do that at the grocery store. Had I not learned that, I would be completely lost. Everybody comes out of their training programs, no matter what profession, they're bright eyed, bushy tailed, and they're ready to hit the ground running. For healthcare professionals, there will be a crash into the business world. Um, and that's something that we have a lot of young clinicians at our organization. We're trying to teach them those business principles so that they understand this is how we have to play this game. There is no mission without margin. We have to have profit to be able to move forward, to be able to invest in you as a clinician, provide additional training to you, provide the best care to our clients. And so that has been a challenge throughout my entire career. There are a lot of healthcare organizations that have both internal medicine or like physical hospitals, physical body, regular medical hospitals. And then they also have a wing of the business that is mental health and inpatient psychiatric facilities. And the business model, the staffing grids in those are the same. But you cannot run a psychiatric unit with 30 psychotic patients the same way that you do an ER or a cardiac ICU or a general admission floor. They cannot be run the same way. They cannot be staffed the same way. But there are no healthcare professionals in those rooms providing that guidance. If they are, they have been out of practice and they have become an executive healthcare professional, and they've been an executive for the last 20 years. So it's likely that they haven't worked on the unit needed to support a team. They're just as far from providing guidance about psychiatric units as they are ERs and pediatric ICUs and all of those things. So I think a huge issue with our industry is that there are people running the business that aren't in the business. And the biggest challenge for healthcare professionals when they come out of school, no matter what training it is, therapist, physician, physical therapist, is we receive no training. I took 0 business classes. Wasn't even an option, wasn't even mentioned as a hey, if you ever plan to own your own private practice, which a lot of therapists, if not most therapists, would like to do someday, you should probably take a business course. Never even suggested to me. And I went to one of the top counseling schools in the country. And so we're not given any kind of guidance on how we're about to interact with the real world. And so it is just such a huge blow. And if clinicians, like, I was probably only a year in to my professional work when I took the biggest hit. And I thought I was inadequate as a professional because I couldn't make change in the system, even though I was so energized. I had so much information at my fingertips. I really cared about my clients. I couldn't change the fact that I was still going to be forced to discharge this person that was floridly psychotic and also very suicidal.
Did you
And
say
so,
floridly?
mm-hmm,
What does that
like,
mean?
um, doesn't know really where they are, hearing voices all the time, seeing things, but we couldn't, this person was uninsured. And the county funding that insured this patient to be there for a couple of days wouldn't allow him to be there for another 2 or 3 more. And so that's when I really came up against the system and felt very inadequate, thought I had chosen the wrong field. Um, and so that was probably my first and biggest challenge, is figuring out, okay, how do I work within the confines of this system and still provide excellent care to my clients? And that's what I'm trying to do as an administrator and an executive now where I am, is I want to create an environment where clinicians, therapists, psychiatrists, nurse practitioners, PAs can come, do the work, provide excellent care, and not have to worry about all of the bureaucracy of business, of state regulations, of the Joint Commission. Let me take care of that for you so that you can provide the best care possible to your patients.
That sounds tough. I mean, having to let people go that still need help because there isn't funding. That sounds tough. Um, and also what you mentioned about this disconnect between our passion and our abilities and our efforts, running up against an environment that we don't yet fully understand, and understanding that we're one piece in a much greater machine, and understanding how to use that for greater effect. I might have delusions of, well, maybe I shouldn't say delusions of grandeur, but I'm going to have aspirations to, let's say, change 1 million people's lives or something like that. And then I realized that actually, a good outcome would being able to change 10. And that's still very significant. But it's just a matter of, rather than throwing away the 10 that I could help by trying to force my assumption of how things work onto the system, and kind of being armed with that, being informed, and being able to work with that from, let's say, day one. I'm curious because you mentioned you went to one of the top schools in the country. What do you think? What's your understanding of, like, where were you supposed to get that information on taking that wonderful knowledge and training, if you will, and then applying it in the real world? Were they just, was that an oversight, or was there some assumption there that was unsaid?
I'm not quite sure because there I haven't spoken to a single person that is an LPC or a social worker that took business classes, or that it was suggested that they take business classes during their master's work. I know that medical school doesn't necessarily include that. Um, so I'm not sure. And so I am making it a responsibility of mine that anytime we have a student intern, I teach them what a P&L is, what is EBITDA, how do you calculate that, why do you need to know that, how will that help you in the future. um, I try to encourage them, like, if you're not going to take a business class, listen to some podcasts, listen to watch some videos, read some books. And I give them, there's some of the more popular people that it's not so data dense, but you'll get to those really data dense people if you listen to the pop culture business people enough. Um, so because of my experience in the clash, I have made it well known to people that like, I'm going to teach you how to be a clinician in this business. Um, so I haven't figured out where almost the responsibility lies in that. I think it's probably all of the above, right?
Usually that's the answer. It's all of the above. That also reminds me, on your website, which looks excellent, by the way, MindBodyO, Mind Body Optimization is your company, and mindbodyo.com is the website. And it mentions dual diagnoses. And that's got to be challenging because it's like, you know, you've got two probabilities kind of overlapping, and it can change somewhat as well. Is everything basically open to being multiple kind of diagnoses? It's very rare that it's just like one thing, like, oh, this is the one thing we found that's wrong with you.
We This person only has anxiety.
Right. Flip this
Um,
switch. Did you check the powers on?
right. Um, so we don't necessarily call somebody that lives with depression and anxiety as somebody that has dual diagnosis. A lot of times you'll see dual diagnosis, meaning substance use and mental health disorder like depression or anxiety. It could also be what we call a process addiction, which is like sex addiction or an eating disorder, gambling. So it's like kind of the process and the mood disorders. That's what makes a dual diagnosis. But just like with depression and anxiety, like it's so hard to tease out, okay, is this person drinking to cover up some kind of pain that they're experiencing? Or are they experiencing pain because they learned how to party in high school and it was a lot of fun? And they kept going through college and after that, and it's created a lot of problems, and now they're experiencing depression because of all the problems it created. So it's a whole, again, we know so much about the brain but we know so little. It's so
Yeah.
hard to tease those things apart.
Yes, it definitely seems so.
Mm-hmm.
Um, Kind of going back to what you mentioned about having to let clients that need your help go because the funding's not there. Are you seeing an improvement? I know that the U.S. Gets some criticism for its like national healthcare or lack thereof of adequate healthcare for everyone. Um, are you like do you as someone who's been in the space for a decade? Do you have like an answer for that? Do you or some ideas for what
I
could work?
wish. I wish. I think this is something that I could talk about all day long. The largest provider of mental health care services is our prison system. 3% of the world's population, but we house 20% of the world's inmates, prisoners. So, like, that's a whole soapbox in itself that I could jump on. Um, but I think if we're really going to be proactive about healthcare in general, not just mental health, but also healthcare, it goes back to education. We have to invest in education of our young people. We have to teach people how to eat a healthy diet. We have to teach children what a healthy relationship dynamic is, what boundaries are, what coping skills are, because if we're not doing that, we're doing them a disservice. If we think about, man, the world is a scary place and all of these terrible things could happen to my child or could be happening to my child and nobody knows. If we would take the time and really invest in education and teach them how they should be treated and how they should treat other people, we may save a lot of heartache. And so for healthcare to make any progress, we have to invest in our education system.
Yes, education, full stop, and then also I'd say the relational like relationships, the mental health
Mm-hmm.
aspect as well,
Mm-hmm.
understanding more about because it's
Right.
almost like, have you seen those maps from back in the day when they didn't have satellite imagery and this kind of like funky shapes of
Mm-hmm.
continents? That's a little bit like what we're like. It's like, yeah, this is the problem. Like, put these
Right.
leeches on your brain, you'll be right as rain
Mm-hmm.
in like a fortnight.
Yeah.
And
Well,
it
and when
Go
I
ahead.
talk about education, I'm talking about not just the kids, right? The kids go home and then they're with their families, their caregivers the rest of the time. So there have to be parent resources, there have to be guardian or whoever is caring for that child. There
Yeah.
also have to be resources for them as well.
Well, that all tracks. No disagreement there. Not that I'd be in a position to disagree with you being the expert, but I wonder too, with our shift culturally into like an atomized lifestyle, where we used to have like tribes and there's a little bit more accountability and visibility, and now it's all about privacy and individuation. When you go from your hometown into a new town, perhaps live in an apartment building, perhaps driving an automobile, there's less like rubbing shoulders with your neighbors. And like I mentioned before about our amazing ability to compartmentalize, we might not get an accurate kind of map of who we are and how we're showing up in the world, because a lot of stuff can just happen on the unconscious level. And then it kind of creates this feedback loop where it seems like the world is wrong. And it could be that we're like driving into oncoming traffic and not even realizing it, metaphorically speaking, hopefully. So, what are your thoughts on that as far as like culturally? Is there anything that we could be doing differently?
Absolutely. I think, every question I could ever want answered is in this thing. And we're seeing, talk about the the bodies being affected. We're seeing kids that have bad necks because they're looking down at their phones. We're having people that have major carpal tunnel issues in their thumbs from texting so much. So we're so focused on social media and having the answer right now. We don't understand distress tolerance, and we don't understand how to pick our tribe. So we're not picking tribes because we don't know how to. I've lived this. I am from a very small town. So, like, my teachers in all throughout school either graduated with my parents or taught my parents. They actually built a bypass around our town. We have two blinking lights and a Dairy Queen. Like, that's what we tout at, right? Um, and so I have moved 2.5 hours from the people that raised me. So when I have a family, if I didn't carefully select my chosen tribe here, I would be all alone and I would be at risk for developing significant health issues, depression, anxiety, a lot of isolation. I'd be in real trouble. But it goes back to that education. We have to teach people how to treat yourself. You teach people how to treat you. We have to teach people how to treat each other. And we have to teach people how to select their tribe. My solid group of friends is about 10 people, and there isn't a single person in there that is like the other. They're all very different. And I've done that intentionally so that if I am ever in need or if my family is ever in need, there's somebody that I can go to for support. So I think socially, it goes back to that education of we have to learn how to choose our support.
That's a great piece of advice there. Choose your tribe, learning how to choose your tribe. And I mean, you mentioned that there's a great deal of diversity in the handful or a couple handfuls of close friends that you have. But I'd imagine one consistency is the feeling that you have going back to your body as a sensor, and that there's trust, respect,
Mm-hmm.
perhaps some playful ribbing. That's kind of can be healthy, but
Oh, yeah.
like a substrate or a foundation of
Mm-hmm.
acceptance,
Mm-hmm.
being seen, being accepted, I think are things that we fundamentally need. And if
Mm-hmm.
those aren't met, we can kind of cut off and pretend that we don't need it, but obviously we do. And that kind of shows up. And it can kind of become like an emperor's new clothes sort of thing where you think,
Mm-hmm.
oh, I've got the world fooled. And it's like, well, people can see. So it
Right.
probably behooves you to go ahead and process it, like rip the band aid off and go ahead and integrate. But yeah, with 8 billion people, not everyone's going to resonate, be your friend or whatever. And it's perfectly fine to recognize when you might be in a situation where that's not your tribe.
Right.
And maybe don't lose hope. You know, your tribe could be right around the corner over the next hill. That said, I think there's a balance to be struck between having a healthy amount of adversity. Not everything is going to be comfortable and unnecessarily kind of suffering. working with others, facing stress. Do you have any kind of guidelines or frameworks as far as like assessing when something is like, am I coddling myself too much or am I torturing myself too much in terms of determining when to remove yourself from a situation or when to kind of know when you found your tribe?
Again, listening to your body. As therapists, we learn how to trust our gut. As physicians, you learn how to trust your inkling when you're making a diagnosis, but a lot of times you don't apply that to decisions that you might make outside of that clinical room or clinical setting. Um, so learning that my intuition is just as valuable when I'm choosing my family, as we call each other. It's just as valuable in that situation as it is in the clinical setting. But two, I believe that conflict is necessary. I believe that conflict strengthens relationship. And if you've got somebody in your life that you just absolutely can't have conflict with, maybe they're there for a purpose, but maybe they're not your first go to. Like I said, I believe conflict really strengthens relationships because we can still have respectful discord and we can come to an agreement in a loving way rather than you're an idiot, you're wrong. Like, what is that? That's not going to push anybody forward. So, if there's somebody in your circle, personally or professionally, that you cannot have conflict with, it's time to really look and see what's the root of this. Is there something that I'm doing? Am I presenting myself in a way that comes off as bullish? Is there another way into having healthy conflict? And if not, then maybe it's time to move on.
Hmm. Well, Sydney, thank you so much for talking with us today. We covered a lot about the evolution of mental health from a patient's perspective as well as a clinician's perspective, kind of going from uh, education into the real world, kind of learning a little bit about the business side of things and taking steps to introduce that if it isn't part of your curriculum already. How to live maybe a little bit of a healthier life, making better decisions with how you spend your time with whom. Is there anything that we didn't get to touch on that you'd like to point out?
I don't think so. You're right. We covered a lot. I enjoyed
So,
chatting with you today.
likewise, yeah, and thank you for what you're doing. It's very important. I hope that uh, you have a tailwind that's funding tailwind that makes it easier to address the needs that are there, and
Mhm.
to point people to the website once again. That's mindbodyo.com. Is that
Mhm.
correct?
Yes.
Is there anywhere else you'd like to point people?
So we do have Facebook, Instagram, and LinkedIn. We share content. There's the quick have a blessed day, but also coping skills, education about different techniques and things like that that might show up there from time to time. So check us out and follow us on those as well.
Okay. Well, thank you.
Thank you so much.